Dr. Padma Shri, Dr. C.N. Manjunath, Professor of Cardiology, Director Shri Jaideva Institute of Cardiovascular Sciences and Research, Bangalore.
First of all, I am very thankful to Microlabs and Icon 2020 for this invitation to be amongst you. The two to deliver a oration on legendary late G.S. Surana, because I know Surana for many years in 90s and beginning of 2000. So G.S. Surana was a great inspirational leader, and he is exactly like a heart actually, because heart is a great philanthropic organ, and it just utilizes 5% of its blood for its own coronary circulation. 95% it donates to the rest of the body. So late G.C. Surana was a great philanthropist, and he has contributed a lot to the society. And he was also like a heartbeat, invisible but continuously supporting life. So to address this particular topic, emerging risk factors in cardiovascular disease, under G.C. Surana Oration, it is a proud privilege, honor, and also a respect. I think this is the sort of respect we give to people who have done so much for the society, because his contributions in the area of health, education is tremendous. Even they have contributed without any expectations to the society. See, that is called real, service. Without anticipation, without expecting anything in return. And his sons are also in the same footprint, and they are following the path of his father, Mr. Dilip Surana. I know him very well, so it's my pleasure. At the same time, I'm very thankful to Dr. Siddharth Shah, the senior most physician and the executive chairman of Hypertension Society, and they're all great pioneers and great teachers, and because of their teaching and academic interest, all these things can happen. And I really thank Dr. Siddharth Shah and all the members, and also those participants who are logged in for this particular lecture. So India has gone into a lot of transition. Nearly 50% of deaths in India today are due to non-communicable diseases. So 25% of deaths in India are due to cardiovascular disease. This is largely because with India's economic growth, urbanization over the past decades, a large section of the population has moved towards unhealthy lifestyle with the decreasing physical activity, increasing stress levels, increasing intake of saturated fats, and also tobacco. So this is one of the reasons why India, along with other third world countries, has seen a sudden surge of non-communicable diseases. So in other words, India is sandwiched between non-communicable diseases on one side and communicable diseases are on the other side. So 50% of mortality and morbidity is because of non-communicable diseases. Cardiovascular disease are the largest cause of mortality, accounting for around 50% of deaths. There is fourfold increase in the prevalence of coronary artery disease in India during last 40 years. 7 to 13% urban sector, and 5 to 7% rural Indians are suffering from coronary artery disease. Way back in 1960, the prevalence of coronary artery disease in India was just 2%. At that time, the main issues were malnutrition, infections. Those were the two issues, of course, poverty and all those things. But today, India has seen a sudden surge of coronary artery disease, and also the rural-urban divide is narrowing. Earlier, it was thought it was a disease of elite class, it is a disease of urbanites. Today, it is equally prevalent among the rural people, so also among the poor people. We look at the cardiovascular death rate in India. It is 272 per 1 lakh population in India, which is 1.5 times more than what we see in the Western scenario. Death rate is 235 per 1 lakh population in Western population. So not only the disease is premature in India, the mortality and morbidity is also high This is a matter of great concern. By 2030, highest number of heart attacks will be in India. 4 people die of heart attack every minute in India. I think for everything in India, it is premature. You talk about diabetes, it is premature. Talk about hypertension, it is premature. Talk about coronary disease, it is premature. Talk about puberty, it is premature. So everything, for all bad reasons, things are happening 10 to 15 years earlier in Indian population compared to the Western population. So these are some of the unique features of cardiovascular disease in India. Number 1, I have already alluded to, it is premature and high mortality and regional variation. Because India, as you know, is a country in diversity with respect to culture, with respect to diet, with respect to lifestyle. So as a result, the disease burden is a little more in southern India compared to northern India for various reasons. And the disease also is not just premature. Many Indians do have a diffuse coronary artery disease, and also the involvement of more than one artery is more common. So these are some of the important characteristics of coronary artery disease in India. Look at the top 10 causes of mortality. You look, just compare 2008 versus what is going to be in 2030. Cardiovascular disease, cancers, chronic respiratory diseases, respiratory infection. Even by 2030, the cardiovascular disease continued to be number 1 cause of mortality. It's a matter of concern. So we need to do a lot of preventive measures. We need to do a lot of precautionary measures. A lot of policy changes need to be taken in this regard to bring down this menace of cardiovascular disease. Before embarking on non-conventional risk factors or emerging risk factors, let me just roll over on conventional risk factors. That is, we have non-modifiable as well as modifiable. Look at age, non-modifiable, age more than 45. When we were medical student, age more than 65 was an independent risk factor for coronary artery disease. See what has happened down the line in the last 30 to 40 years. The age more than, that means the age at which the heart disease is happening is coming down steadily. Age more than 55 for women. In fact, age more than 70 in women used to be the risk factor about 40 years back. Even the coronary artery disease is catching up among women, because many women today are working like men, except for reproductive issues. I think they are exactly working like men, what we call it as menish women. And also they are exactly the banks where all problems of the family, the children education, looking after the husband, everything is getting deposited in a bank called women. So as a result, whatever immunity they had during the reproductive phase or a premenopausal phase is weaning away. Then, yes, family history. In our data, I'm going to present a little later, nearly 12 to 15% of patients had a strong family history. The definition of family history is, if somebody or some members in the family, if they die of coronary artery disease before the age of 50, it is considered to be a strong family history. Suppose if somebody in the family dies of at the age of 80 or 75, it is not considered to be a strong family history. So a premature death occurring in a family, such family members are more prone for cardiovascular disease. Then under modifiable risk factors, we have smoking, unquestionably an important risk factor. Diabetes mellitus, coronary artery disease is 5 times more common among diabetics than non-diabetics. Elevated cholesterol. There is some misconception in the society that only those who are obese, those who eat a lot of fat will have a high cholesterol, but even thin individuals, even underweight individuals can also have high elevated cholesterol. High blood pressure is also an important thing. Obesity. But in India, if you look at the phenotypic pattern of coronary artery disease, nearly 35% who suffer from coronary artery disease are not, they are not obese. We have what is called thin fat individual. Their BMI is normal, but they have a central obesity. This is nomenclature is called, thin fat individuals. Lack of exercise, yes, this is also being observed. This is a usual risk factor, physical inactivity. In fact, the data coming from various societies, if you walk at least 45 minutes daily, the average lifespan increases by 8 to 10 years. Then, yes, type A personality. I think is also a more important modifiable risk factor, the attitude of a person. The type A personality has got a huge impact on the occurrence of coronary artery disease, not only to that person, even for people around. So type A personality are those who are extremely eccentric, who are arrogant, doesn't like others, they're jealous of others, and they're sarcastic, they're, they don't don't provide space for others to grow. So these are the type of personalities. Sadistic attitude people are more prone for cardiovascular disease. Alcohol in excess. Alcohol in excess, I have just used that word alcohol in excess for a simple reason, because yes, there are some evidences that alcohol in moderate doses is beneficial to the heart. But as doctors, we cannot give alcohol as a prescription for a simple reason. What patients or the public remembers is doctor did advise to take alcohol a little bit, but that dose what doctor has mentioned, they conveniently forget. And some people keep on telling that we take alcohol occasionally, but for most people, these occasions come regularly, so it cannot be a prescription. Alcohol in excess is an independent risk factor for hypertension as well as for coronary artery disease. Then, just in a lighter vein, alcohol is also a device which converts silence into a speech. So, which converts silence into a speech. And there is also another device, just again in the lighter vein, a wife, which converts speech into silence. So, stress is an important risk factor. I will come back to that. And lifestyle also is an important, particularly people going for social and economic comparisons. That's where they get into problem. Only you should compare for coming up in life, not out of, frustration. So social and economic comparison are also. So these are the usual, well-known, conventional risk factors. Unfortunately, 30%, sometimes even up to 30 to 35% of Indians do not have any of these conventional risk factors who suffer from cardiovascular disease. So that opens up a question. So what are the other factors? We have to look beyond these conventional risk factors. So the emerging risk factors are directly associated with the risk of cardiovascular disease, but their causative, quantitative, independent contributions to cardiovascular disease were not fully elucidated as opposed to conventional risk factors. So a lot of emerging risk factors we are discussing, but again, we need to really study in depth what is the causal relationship of these each of these emerging risk factors. They help to reclassify intermediate patient risk for major coronary artery disease requiring more aggressive risk reduction. That is the whole objective, because we know about conventional risk factor, but we should also know equally about the newer or the non-conventional or the emerging risk factor, so that appropriate preventive measures, risk reduction measures can be taken. These emerging risk factors are measurable, improve cardiovascular risk assessment, assist the clinician in making decisions concerning patients at incremental risk for specific diseases. So what are the emerging risk factors for cardiovascular disease in India? One is central obesity. This I already said, what is called thin fat individuals. BMI may not be abnormal, but still they have a higher density of fat. Dyslipidemias, various types of dyslipidemias, insulin resistance, elevated plasminogen activator inhibitor, then infection theory. In fact, it was thought whether virus could be a cause. whether bacterial infection could be a cause or just a non-specific inflammation, because atherosclerosis in nutshell is a diffuse vascular inflammation, because CRP, you can see many patients of atherosclerosis have a high CRP, which is again a marker of inflammation. And we have fibrinogen level. Homocysteine is also another important risk factor, particularly in young patients who presents with acute MI without an obvious risk factor. Fetal malnutrition. There's an interesting correlation between your birth weight and your future occurrence of coronary artery disease. Those babies who had a low birth weight, or those who had a very premature birth and also had a low birth weight, when they grow into adulthood, they have developed premature coronary artery disease. They have also developed diabetes mellitus. This is the explanation is there is an immature the growth of tissue and the muscle cells, particularly the vascular smooth muscle, not properly developed in these. As a result, they are more predisposed to early atherosclerosis, early occurrence of diabetes. So fetal malnutrition and low birth weight is linked to occurrence of premature cardiovascular disease, so also diabetes mellitus. So stress, I already said, alcohol, said fast food, the refined carbohydrates, simple sugar, saturated fats. Today, the data is very clear. Sugar is more dangerous than, carbohydrates are more dangerous than cholesterol. It's extremely important. We need to cut down the carbohydrates, the simple sugars, lack of fruits and vegetable consumption. In fact, as for the one of the CFTRI data, only 12 to 13% of Indians do consume an optimal quantity of fruits and vegetables. Abdominal obesity, non-alcoholic or alcoholic fatty liver disease. Then we have pregnancy-induced hypertension, gestational diabetes mellitus, and polycystic ovary diseases. So these are some of the things we are looking at, whether what is the role in the occurrence of premature coronary artery disease. So going beyond this, the ethnicity, Asian Indian ethnicity, first degree relatives, and again recurrent abortions, then the infertility, and again the BMI issue I've already said, and elevated triglycerides. This combination is pretty common in Indian context. High triglycerides, low HDL is also more atherogenic, elevated fasting insulin, elevated lipoprotein A, and elevated ApoB to ApoA1 ratio, and vitamin D deficiency, hypothyroidism. These are some of the things which are making rounds. And vitamin D deficiency, in fact, we did a vitamin D evaluation among all the doctors in our institute. Nearly 70% had a very low vitamin D deficiency, and I will come back to that later. So other emerging risk factors, the list continues: aspirin resistance, adenopectin. Then we have this, of course, there is a difference between risk factors and risk markers. Risk factors are those which are the causes for atherosclerosis, but as a consequence of atherosclerosis, then there could be elevation of C-reactive protein. So one need to really split, demarcate between the risk factors and the risk markers. Risk markers are the consequence of the coronary atherosclerosis. Of course, all these have been studied. They're said to play some little role in the occurrence of atherosclerosis, such as myeloperoxidase. Then we have F2 isoprostenase, vitamin D, and the C-reactive protein I've already said. Then what are the genetic risk factors? Some genetic studies also have been done looking at why some Indians without conventional risk factors are developing coronary artery disease and landing up in acute myocardial infarction. So various genetic studies, the genetic mapping has been done, and this is some of these substrates are more prone for atherosclerosis. So this is interesting. See, you look at this is what the one of the contributing factors over a period of 60 years. What is the family pattern? How family pattern has changed, and how our culture has changed, resulting in lot of stress and also loneliness, which is also an important cause for premature non-communicable diseases, whether it is hypertension, diabetes, or coronary artery disease. Look at the family concept of 1960. More people, a lot of smile on their faces, and they are living, parents are living with grandparents and their children, and it's a happy family. And in 1960, the prevalence of coronary artery disease was low. Then you look at after 20 years, yes, more or less, still continues to be a joint family, and they are still happy. Then coming back to 2000, after another 20 years, it was reduced to 2 per children, but still they were happy. Now we are in 2020. So definition of joint family in 2020 has terribly changed. And if husband and wife are together, that itself is called joint family. Unfortunately, look at 2020. They are physically, yes, close to each other, but mentally they are apart. And this is the one of the important reason why all this today, loneliness, 1 in 8 in India are suffering from loneliness syndrome, which is an important cause for hypertension. At least a precipitating cause for hypertension, diabetes, and coronary artery disease. So, in fact, we are living in an era of what is called EDR syndrome. EDR syndrome is nothing but internet-derived information obstructing treatment. This is one of the reasons why we doctors are today are exposed to high levels of stress, because we are always internet-driven. Stress is also causing a lot of problems among the healthcare professionals. So loneliness syndrome is one of the important cause for high blood pressure, diabetes, and as a result, a lot of stress in the family, and they are not able to share. In 1960 or 1980, if there is any problem in the family, they used to settle there itself, and the family itself used to be a community center. Family itself used to be a counseling center, and family itself used to be a kindergarten school. So all these things, because only husband and wife with one kid, a lot of stress, and professional stress, the academic stress, and also a career stress, all culminating in more prevalence of premature cardiovascular diseases. Then we have what is called a sitting disease, but ultimately it is a physical inactivity or modern sedentary lifestyle, both at home and in workplace, are costly for us and for our employees. So sitting disease, is a new tobacco. Sitting more than 4 hours in a day causes a lot of problems. These are some of the research data says sitting more than 6 hours a day decreases the lifespan of men by 20%, decreases the lifespan of women by 40%. And these are all relative data. 21% increase in breast cancer complaints and 21% increase in diabetic relative. This is not absolute figures. And in a way, a sitting disease, we call it as a sitting disease. So if somebody is sitting in a particular place, in one place for more than 4 to 5 hours, it is equal to smoking 5 cigarettes. So another reason for this sitting disease, particularly ladies at home watch a lot of TV serials, and you believe me, some of these TV serials never end in this generation. So another important emerging risk factor is air pollution. Globally, 7 million premature deaths are attributed to air pollution each year. In India alone, 1.3 million deaths in India are due to air pollution. In its health impact, air pollution is as bad as an hypertension or smoking or physical activity. So air pollution is a new public health problem. Air pollution is a new tobacco, and particularly the particulate matter less than 2.5 are the reasons for atherosclerosis and clot formation in the coronary arteries. These are some of the evidences. Heavy pollution increases heart attack risk. United Kingdom study. The major pollutant particles are carbon monoxide, nitrogen dioxide, sulfur dioxide, and ozone. So particularly the particulate matter PM less than 2.5 micron passes through the lung filter, and they have studied and demonstrated when they are exposed to chronic air pollution, their particles have been demonstrated in the vessel wall, and they stimulate atherosclerosis and also causes vascular inflammation and also promotes clot formation. So these are some of the ambient air aerosols and cardiovascular effects. You can see here all-cause mortality, myocardial infarction, atrial fibrillation, sudden cardiac death, peripheral arterial disease exacerbation, and increased blood pressure, stroke. So these are the acute cardiovascular effects. And if you look at the chronic effects, yes, it can cause atherosclerosis. So a sudden exposure to a large amount of air pollution can have both acute effects. What we are interested in this particular topic is the chronic effects of air pollution. So definitely the all-cause mortality and cardiovascular mortality increases due to air pollution. So another important thing one has to understand is the genetics can change, genes can change when there is an interaction of the environment with the behavior of a particular person. So that is how there can be a genetic mutation, and the occurrence of disease can come in, as a new thing in some families where there was no incidence of coronary artery disease in their ancestral generations. So the interaction between the environment and also with the personal behavior can also cause mutation. So these are the important issue. Then I want to emphasize, we have done what is called a first attacks survey in Jaideva Institute of Cardiovascular Sciences in the last 2 years. This is the largest documented registry follow-up clinic for patients with premature heart attack. We have selected all patients who are admitted for treatment of acute myocardial infarction under 40 years. And in the last 2 years, we have enrolled for this registry 2,200 patients for our study. And every month, we at Jaideva Institute admit 150 heart attack patients below 40 years of age. In fact, we are interested to look at the risk factors profile in young myocardial infarction patients because the data is robust, and also many studies are available with respect to the risk factors in adult or older heart attack patients. But we wanted to study the prevalence of various risk factors below 40 years. So look at the age group, the age distribution in this particular survey. So 17% of patients were between the age group of 26 to 30 years, and 33% were between the age group of 31 to 35 years, and 45% of these young MI patients were in the age group of 35 to 40. That means 17% of patients with acute MI were below 30 years of age. Then we were analyzing the risk factors in this age group. Look at this. Diabetes was seen in 11%, and hypertension in 9%, and dyslipidemia in 14%. This is contrary to what we see in adult or elderly people, because in elderly people are above the age of 50 or above the age of 55, nearly 40 to 45% do have diabetes, hypertension, and dyslipidemia. But in younger patients, young heart attack patient, the prevalence for diabetes and hypertension was less, and 51% were smokers. So smoking was number one risk factor for heart attack in young patients, and family history of 16%. 16% of these young heart attack patients had a strong family history, and no conventional risk factors in about 33%. So 33% of young heart attack patients did not have any conventional risk factors. So this is a very important public health issue. We need to look why this young population are prone for atherosclerosis at an early age. So only smoking was seen in 50%, but otherwise 33% did not have any conventional risk factors. Even diabetes and hypertension was there in just a small number of these young patients. Then we dissected the patient profile of this premature coronary disease patients. You look at this, rural it was 31% and 69% were urbanites and 34% were consuming alcohol, and then there were more non-vegetarian, 65% were non-vegetarian, and interestingly 9% were women in below 40 years of age, so which we never used to see about 4 decades back. So 9% of young women below 40 years had an heart attack. So these are some of the conclusions we draw out of this study. 40% of patients had a high fasting insulin and had a borderline HbA1c levels. This implicates the role of pre-diabetes, insulin resistance as a strong risk factor for heart attack in young Indians. So these are some of our observations. And low HDL with high triglyceride is found in most of these, whatever 10% patients had a abnormal lipids. So low HDL with the high triglyceride was the usual pattern, and role of LDL as a risk factor was not seen in young patients, unlike in Western population or in our own Indian adult population. 36% of these young patients had a high lipoprotein A, and 69% of these young patients had high homocysteine levels. So any young patients presenting with acute myocardial infarction, we need to estimate the homocysteine level because it is more thrombogenic and it is treatable, and it can prevent the recurrence of acute myocardial infarction. And 73% had low vitamin D levels, and only 22% were overweight, and 9% were obese. So 72% of these patients had abdominal obesity. So BMI was normal, more or less normal in nearly 2/3 of this patient, but still they had a central obesity, what you call thin fat individuals. In women, polycystic ovary and irregular menstrual cycle seems to be associated with premature heart attack. Although in Western population, BMI of 18 to 25 kg per meter square is considered within normal range, but among Indians, we all know anything about anything at 23 kg per meter square is considered to be a cutoff point and indicating a higher risk for metabolic disease. And fatty liver seen to be a manifestation of underlying severe insulin resistance. So these are some of the observations made because nearly 35% of a young heart attack patient did not have conventional risk factor. Even LDL was normal in this group. Only the lipid abnormality that was seen was triglyceride, high triglyceride and low HDL, that too in a small percentage of these patients. Another interesting thing is to know about what is the coronary artery disease burden in young physicians. Work stress increases the heart attack risk by 23%. See, a couple of studies have confirmed the average lifespan of a modern day physician or modern day aggressive interventionist is getting reduced by 10 years. Very unfortunate. We doctors, we need to take care of this, and stress management is extremely important. And so work stress, according to this study, work stress increases the heart attack risk by 23%. In the beginning, I was talking about an idiot syndrome. We are living in an era of idiot syndrome. Idiot syndrome refers to internet-derived information obstructing treatment, and patients and their attenders come and present before the treating doctors with the floods of internet-derived information, that confuses the doctor, that also confuses the patients, at the same time puts a tremendous stress on the physicians and the treating doctor. This is one of the important things. Unfortunately, we have to manage this very meticulously, and good communication, and we need to talk to ourselves how best we can reduce the stress. For example, I will tell you, for the same patient, 10 to 12 phone calls you receive, you look after the patient well. And immediately, impulsively, anybody say for the second recommendation, third recommendation, now why you are calling so many times, so many people are calling on the same patient. So in that process, we are stressed, even they are also not happy. So to keep the story short, you just in 1 second you tell, yes sir, we look after. So this is how we need to manage stress. As head of Jaideva Institute of Cardiovascular Sciences, daily we see about 1,500 outpatients, and we do India's highest number of angioplasties and angiogram in the center. And annually we do around 40,000 cath lab procedures. Lot of people come for concession, being a government organization, and they bring 5-6 recommendation letters to reduce the cost of the bill. I always, already even before receiving the letter, I would have given 20,000 concession, 30,000 concession, depending, because we follow a policy of what is called treatment first, payment next concept. I strongly believe life is more important than file, and humanity is priority. And after giving this discount, this is just, I think this is my practical advice and tips to my young physician colleagues. So moment they ask another 20,000, then you keep shouting, I've already given 30,000 discount. Why are you bringing these letters and all? But what I will tell, because you have brought these letters, I have given 20,000 discount. This is how you should go on convincing yourself without getting stress. So work stress and reduced health in young physicians, evidence from Swiss registry. So coronary artery disease among young drivers. I think we have done a study, 25% of heart attack patients admitted to our Jaideva Institute. We have done a study, of them 25% were drivers actually, indirectly suggesting they are exposed to air pollution. Many of them were non-smokers, but they had a very high levels of hemoglobin. Then coronary artery calcium score is an important indicator of atherosclerosis, correlates well with the risk for future cardiovascular event. In Indian study consisting of 306 subjects, 35% had diabetes, 47% had hypertension, 18. So coronary calcium is an important risk, it's a predictor of coronary artery disease. It is a very simple, non-invasive thing. Just it takes hardly 1 minute. No contrast is required. Presence of coronary calcium is synonymous with atherosclerosis. It is extremely useful in planning the treatment strategy. Then, because many people ask us, diabetic patients, hypertensive patients, I don't have coronary artery disease, can I take aspirin? Now, at this point of time, you cannot take aspirin as for a primary prevention. But if there is a coronary calcium, yes, such patients, we need to be treated with calcium score. Do you have time or? So C-reactive protein, it's not a risk factor, but it is a predictor of, it's not a risk factor, but it's a risk marker. And those with C-reactive protein. Yes, Dr. Manjula?
Sir, you can complete, sir.
Yeah, fine. So those who have high C-reactive protein, they are predictor of MI, stroke, peripheral arterial disease, and cardiovascular mortality. So these are some of the data. Again, carotid intimal thickness. These are the non-invasive evaluation of atherosclerosis. So suppose if carotid intima medial thickness is more, and such patients are likely to have a coronary artery disease. So it's not a risk factor, but it could be a risk marker. So also lipoprotein A, will not get into all these things. Apoprotein B, certain studies indicate ApoB to be more closely related to risk of vascular disease than LDL-C. And of course, direct measurement of total number of circulating atherogenic particles. So I think this is been talked about many times, and young patients presenting with acute myocardial infarction should have a homocysteine evaluation because it is treatable, and also you can prevent future recurrence of myocardial infarction. So strong, there is, I don't say a strong association, there is some association exists between low vitamin adverse cardiovascular outcome, including high blood pressure, diabetes, obesity, and hyperthyroidism. We have studied vitamin D levels among doctors in our institute, including myself. We had a low vitamin D, and now after vitamin D supplementation, this thing, but it has been found those who have atherosclerosis, those who have diabetes, those who have hypertension, said to have low levels of vitamin D. So these emerging risk factors are definitely measurable, and understanding them will go a long way in taking precautions and also in advising patients for modifying these so-called emerging risk factors. Ultimately, the whole objective is to reduce the burden of cardiovascular disease, both premature as well as cardiovascular disease in the adults. So because so to keep your heart healthy, because heart always says you just walk 1 hour for me and I will beat continuously beat for the rest of your long life. That's what great heart says. And for a good heart health, keep 5 things as low as possible. That is blood pressure, blood sugar, blood cholesterol, waist circumference, and body weight. Lastly, or ambition. So again, I thank Microlabs and also this high conference for this opportunity to address this oration in the name of great GC Surana. Thank you very much.
Thank you, Dr. Manjunath, for the scholarly rendition of the GC Surana oration. I think this is an oration, so there will be not question answers, but we will discuss throughout the conference whatever points that you have brought out, especially during COVID times. We all see people sitting around. So your point of sitting and coronary artery disease is a bigger stress. Thank you, sir. At the outset, I would like to point out that Dr. G.S. Wonder, who is following us, has been my partner in bringing out the 4 guidelines. So I would welcome Dr. Chopra and Dr. Wonder, because he has been working hard for the last 20 years for the guidelines. Thank you, Dr. Manjunath, for giving us the real view of physicians having the risk factors for cardiovascular disease. Thank you, sir.